Hi everyone, it's Dr. Alicia. So many of us, including me, got drawn to a career in medicine because of TV shows like House MD, where, Hugh Laurie just seemed like this absolutely amazing diagnostic doctor who was able to know the answer to every patient's really complicated diagnosis. I wanted to be like that. And now that I am a practicing internal medicine doctor, I have a framework for how to actually solve these tricky cases in real life. Today, we'll be talking about my 5 steps of clinical reasoning to help you solve any case, which is what I've been teaching internal medicine residents for the last couple years. So a lot of other specialties, they do procedures, they do surgery. We say that in internal medicine, the procedure that we do is clinical reasoning. Clinical reasoning is what allows us to be diagnosticians that can solve difficult cases. So today we'll be solving a case together of a 20-year-old woman who has difficulty breathing and this cough, and all of it is getting worse despite treatment over many months. So what is really her diagnosis? So that's what we'll be talking about as we solve this case together. So the 5 steps of clinical reasoning that we are going to go through right now are 1, defining problem, 2, using a schema, 3, matching our patient's specific case to illness scripts for conditions that we think could be what they have, 4, comparing and contrasting our top 2 or 3 diagnoses, and then 5, making a commitment to where we think the cards are going to land, what diagnosis we think the patient is really going to have. So let's get started with 1, problem representation. If we want to actually solve a problem, we need to be sure that we've figured out exactly what the problem is. I know this is a very silly meme of a man who is sinking and sinking with his car while he's absolutely fixated on like an engine problem. But this does happen in medicine, where people can be so fixated on one thing that they think is the problem, whereas the problem's actually something else. So if you don't properly identify your problem, you're not going to get the right answer that is going to actually fix the patient's issue. So the way that we think about problem representation is, how can we generalize what is going on? Who is this patient? Are they male, female, trans? Are they old, middle-aged, young? What syndrome is it? Is this like an abdominal pain syndrome? Is this like a syncope syndrome? What is the time course? Is it acute, subacute, chronic? Is this an onset that was slow or fast? So these details are what will help distinguish between different conditions, because some conditions tend to affect more young people or tend to present more acutely, for example.
Just a quick disclaimer that this case is really for teaching purposes, for the purposes of educating future doctors, and is not meant to be used as medical advice. In the video description below, you'll see a link to a handout that goes along with this case that gives you a spot to write down your thoughts at the different places where we'll pause. So feel free to open up that handout.
So we're going to get right ahead with our case now. So a 20-year-old woman sees you in clinic for her persistent cough and shortness of breath whenever she walks a block. You saw her in clinic actually 6 weeks earlier for nasal congestion, rhinorrhea, post-nasal drip, and cough. And you had prescribed her fluticasone nasal spray and loratadine, which helped her resolve her nasal congestion, but the cough continues to persist. So the cough is worse at night, and she can hear herself wheezing during these coughing episodes. She used a friend albuterol inhaler during one of these episodes, which seemed to help. Her symptoms occur both at home and at work. And in terms of review of systems, there's no fevers or chills, no sputum production, headache, joint pain, muscle aches,
heartburn, nausea, vomiting, no exposure to mold, smoke, cockroaches, or mice. Her past medical history is significant for migraine headaches, allergic sinusitis, and being overweight. And her medications include the fluticasone, loratadine we talked about, and benzonatate as needed, and she has no known drug allergies. She was born in the Dominican Republic, lives in Boston, works at a daycare center, and has a pet dog. She never smokes, never does drugs or drinks alcohol. And her mother had allergic rhinitis, her sister had childhood asthma, her uncle had lymphoma. On exam, she has an O2 sat of 96% on room air. She had normal nasopharyngeal mucosa, and she had diffuse high-pitched expiratory wheezing and increased an increased ratio of expiratory to inspiratory time. Okay, so we're going to practice that first step of problem representation. So can you take a moment here, pause the video, and describe this case in 1 or 2 sentences with the relevant semantic quantifiers, meaning young or old, what's the syndrome, is this acute or chronic? All right, so if you've taken the time to write down 1 or 2 sentences describing how you are seeing this patient's problems at this time, I will show you what my problem representation looks like. So there is no like perfect problem representation. This is just a way of how my brain is currently, thinking about her problems. So I see this as a young woman with allergic sinusitis who presents to clinic with subacute cough and shortness of breath, as well as URI symptoms that resolved with allergy medicine. She's found to be wheezing diffusely with an increased ratio of expiratory to inspiratory time. Great, so what is that most likely caused by? We're trying to just recognize a pattern that is something commonly seen, which in this case is asthma, right? So this is someone who has 2 of the 3 things of the atopic triad, which is allergic rhinitis, asthma, and eczema. We don't hear anything about eczema, but she does have the other 2. And so you diagnose this patient with asthma and you order a albuterol inhaler and you refer her for PFTs to confirm this diagnosis. So here are her PFT results. They got done very, very quickly. So her PEV1 is 1.37 liters, 35% of predicted. Her FEV1 to FEVC ratio is 0.58, which is 67% of predicted. And then after she received bronchodilators, her FEV1 increased by 300 cc's to 1.67 liters. So does she have asthma? Does this meet criteria for asthma? Here is my very general guide to interpreting PFTs as a generalist. So FEV1 to FEVC ratio less than 70% equals someone has an obstructive defect. She meets that criteria since her ratio is 67% of predicted. And then if someone has a low FEVC or total lung capacity, then that suggests that they have a restrictive issue where their lung cannot expand enough. So for her, that is not something that we have information about. And then for people who have obstructive defect, asthma is associated with reversible obstruction. So they have to meet criteria of a positive bronchodilator response with their FEV1 increasing by at least 12% and by at least 200 cc's. So she actually meets that criteria as well. So she has, by definition at this point, asthma. So what do we do next? Typical treatment for asthma is a inhaled corticosteroid and a long-acting beta agonist bronchodilator. And then she also keeps using albuterol as a rescue inhaler in case of asthma flare-ups. Her symptoms worsen though despite these treatments, and they do not even improve when you add even more asthma treatment with montelukast and a long-acting anticholinergic bronchodilator. And you see her in clinic 6 months after her first visit with still having cough, still short of breath, and still wheezing. So at this point, you've known her for many, many months. On exam, her temperature is 37, heart rate 69, blood pressure 108/57, respiratory rate 18, O2 sat 97% on room air, all looks pretty good. In general, the patient looks anxious and uncomfortable, but she was not in acute respiratory distress. Her exam was significant for normal conjunctiva, oropharyngeal and naropharyngeal mucosa. Her sinuses were not tender to palpation. There was no discharge. There was no allergic shiners, which are associated with allergic rhinitis, which is when you have all of this congestion from the rhinitis, and it causes you to have like these super dark under eye circles that look like you got like punched in the face. So luckily she does not have that, and then no lymphadenopathy. And on her chest exam, she has prolonged expiratory phase with mild expiratory wheezing in both lungs, no crackles, agophony, tactile fremitus, or dullness to percussion. And basically her cardiac, abdominal, neuro, and extremities are all pretty much fine. There's no signs of edema, jugular venous distension, or anything. So now we've gotten a lot more information about what's going on with her. So can you describe this case again in 1 or 2 sentences using the relevant semantic quantifier so that we can say, what is this patient's problem now that, it's different, 6 months have passed.
So take a moment to pause the video and write down your problem representation. Please feel free to share it with me in the comments below, because I love to hear how you are thinking about this case now that we are 6 months in. So I'm going to show you what I was thinking about this patient as I was going through it. So my problem representation is that this is a still young woman with allergic sinusitis and this diagnosis of asthma, who presents to clinic with now a chronic cough since it's been over 8 weeks. Still shortness of breath and wheezing despite the usual asthma treatment. So at this point, are there any questions that you have? Like, isn't it weird that this woman who's so young, and sounds like someone with typical asthma, is just not getting better despite escalating standard of care for asthma? So one thing I was thinking is like, okay, should we take a step back and think what else could be causing this chronic cough besides asthma? Another thought I had was what presents like asthma but isn't asthma? So now we can go to step 2 of our 5-step process. Step 2 is using a schema. So at this point, let's write down on a piece of paper your schema, which is your approach or algorithm for thinking about the causes of chronic cough. So any good schema would include must not miss really emergent kind of diagnosis, as well as the common causes like asthma and some zebras, some more rare causes of chronic cough as well. Is there a way that you typically approach a patient that you would see in clinic or in the ED with chronic cough? So here is one possible schema for how you might approach chronic cough that I found on a Google search. Thanks to Dr. Jarrell Diaz for creating this and sharing it with learners. It, categorizes it by irritants or exposures, airway diseases like asthma, other organ systems that can cause chronic cough, like heart failure, if you have pulmonary edema, that can cause chronic cough, autoimmune diseases, vasculitis, ILD, or GERD is a very common cause of chronic cough, malignancies, and then there's also kind of like this other bucket of atypical infections, to which I added strongyloides and aspergillus, eosinophilic disorders, and then habit coughs. So this is, one possible approach to chronic cough. It's always really helpful when you spend time writing down your own schemas to compare it with someone else's and see
Is there something that this other schema includes that my schema left off? And think like, oh, I forgot to include heart failure as a cause of chronic cough. And so when I think about my chronic cough schema, I need to make sure to remind myself of that, because I tend to forget maybe these other organ systems. As an example, it's so helpful to compare your schemas with a really good one like this that is pretty comprehensive. The other way we could call this problem is asthma that's not asthma, aka like an asthma mimic. So if you do a quick Google search for that, you can come across like some possible schemas. Next, I'm going to show you the labs. So here you see the basic metabolic panel looks pretty much okay. And the WBC is 20.7, and 53% of that is eosinophils. So that is a buttload of eosinophils. So having more than 500 eosinophils is eosinophilia, and more than 1,500 is hypereosinophilia. In this case, this patient has like 10,000 plus eosinophils, and so this is definitely qualifying for hypereosinophilia. And we also have a negative ANA and negative ANCA here. One more factoid about how to think about problem representation. You want to use the most specific problem that you can. What is most unique and defining about this patient's illness, aka what of their symptoms has the shortest differentials? So for example, shortness of breath has a really broad differential. Chronic cough, we just saw, has like 20, 30 different diagnoses on that list that are possible. But eosinophilia actually is a very specific type of symptom in that it has a pretty short differential list. So I'm going to say here, let's focus with our problem not being chronic cough, not being asthma mimic, but eosinophilia, because I think that this is something that is really going to help us come up with the shortest differential so that we can solve this case as efficiently as possible. Let's pick eosinophilia as our schema. Can you share what is your schema approach for how you think about causes of eosinophilia? You want to include, as usual, any must not miss diagnoses, common causes, and zebras as well. So please take a moment to write down your schema for that. And then also, I'd love to hear your schemas if you want to share it in the comments below. So don't worry if your reaction to this is, I don't have a schema. I don't know how people are getting these schemas or how they're able to just sit and write down a schema. So this is what we practice in internal medicine is, you become familiar with some of the schemas that you use more commonly, like alternate mental status, shortness of breath, and then over time, as you're comfortable with the more familiar stuff, you can start building your knowledge on less common, more exotic kinds of schema, like eosinophilia. So the analogy that I give my residents is the first time that you are driving to your friend's house on GPS, you are looking at that GPS for like every turn you're supposed to make. You're just completely relying on that GPS because you've never been there before. But if this is like your 10th time driving to your friend's house, your brain automatically knows the road. It knows where to exit, make the turns. And so it just takes time to basically build those neural pathways. And so that's why we practice writing down our schemas. A possible schema for eosinophilia is China. I really like this because I am from China, and so I'm not ever gonna forget this acronym. There are other schemas out there. So if you Google clinical problem solvers, they have their own schema that they use. So the conditions are Church-Strauss vasculitis, although we're moving away from naming diseases after people, and so this is also known as eosinophilic granulomatous polyangiitis, or EGPA. Helminths is the H, so things like strongyloides and some fungal conditions can cause eosinophilia. Idiopathic, So there are patients that can get hypereosinophilic syndrome, where eosinophils can infiltrate many organs in their body. There's N for neoplasm. So some lymphoma, some leukemias can cause eosinophilia. A is for allergies, asthma, aspergillosis, and adrenal insufficiency. The good news is now we know that this patient's shortness of breath, worsening cough with associated eosinophilia it has to be caused by one of these conditions. This is the wonderful thing about using a schema, is that even if at this moment we still don't know exactly which of these is the right diagnosis for our patient, we have limited the suspects dramatically. The next step is matching our patient's case with the illness scripts for these different conditions that are on the China mnemonic. Prioritize your schema for which causes of chronic cough for this young, stable patient with eosinophilia seem the most likely for her. In order to do this, you have to actually know how does each of these conditions present, and does that sound similar to what she had. This is where a lot of learning can happen for students and residents in internal medicine, and for attendings, who there's so many diseases, there's always more to learn. So in order to know, does this patient sound like she has EGPA, we have to know, how does EGPA actually present? So we're going to go through some of these. Churg-Strauss, or EGPA, it is a kind of vasculitis in which patients present with chronic rhinosinusitis and asthma, but it can affect any organ system. So they can develop skin nodules, neuropathy, glomerulonephritis, and who gets it? It can start as early as people who are in their 20s and 30s, where it can just seem like they have allergic rhinitis and asthma. There's a later stage called the eosinophilic phase, where the eosinophils start to infiltrate more organs, like the lungs and the GI tract. And then there's a kind of more final vasculitic phase that is characterized by just non-specific constitutional symptoms as the vasculitis kind of takes over the body, and the patient's having fevers, weight loss, malaise. This is one of the causes of fever of unknown origin. So does this sound like something our patient might have? Yeah, maybe she's in that prodromal phase. She's in her 20s, maybe she's very early in the disease course where she's not having other organ dysfunction, but she's having the allergic rhinitis and asthma part. How would you diagnose this? It can be suspected in patients who have hard to control asthma, chronic rhinosinusitis, and eosinophilia. They may or may not have other organ involvement, and actually only half of patients have a positive ANCA. So remember, our patient has a negative ANCA result, so that doesn't necessarily mean she doesn't have this kind of vasculitis. The kind of more definitive diagnosis is on pathology showing eosinophilic infiltration of blood vessels or necrotizing vasculitis, or if you're unable to do a biopsy of a possible involved organ, you have to exclude literally every other possible condition, which can be quite difficult to do. For the H in China, we have strongyloides infection as a helminth infection. So how does that present? Does that look like what she could have? So acute infection, you have urticaria, where the helminth is entering the skin, kind of streaky red rash around that area. Patients can have dry cough, GI symptoms. They can have no symptoms for decades. The chronic infection can look like some urticaria, some, intermittent diarrhea, some chronic cough and wheezing, which interestingly enough, I read can be worsened with steroids. And who tends to get this is people living in tropical areas, but it can happen to people living in North America if they've traveled or they're an immigrant. This is where that social history for our patient, where she's from the Dominican Republic, so she does have some risk factors where she could be someone who could have gotten it, maybe was asymptomatic, and or maybe now she's starting to develop respiratory symptoms that could be a sign of this. So could she have this? Sure, maybe. And then how would you diagnose it? So checking serologies, but these are not 100% at detecting whether your patient could have strongyloides. And so oftentimes if you do suspect this, you would just empirically treat with ivermectin and see if the patient improves. So this is one situation where there is evidence for using ivermectin. Another condition, that this is one of the A's in China, is allergic bronchopulmonary aspergillosis. So how does that present? It is a hypersensitivity reaction to having aspergillus colonizing the lungs of people specifically with asthma or cystic fibrosis. And the way it presents is it looks like you have recurrent asthma exacerbations. You just have it looks like you have really bad asthma and you keep getting flare-ups. Patients can also have fever, malaise, sinusitis. And the way that you diagnose it is there may be, x-ray findings. There can be, of course, eosinophilia. There's not like a strict set of criteria, but in general, these patients tend to have IgE levels against aspergillus that are high, aspergillus skin test being positive, high IgE concentrations in general. So having at least like 2 out of the 3 of those can, suggest ABPA. So could this be our patient? Could she be someone with asthma? Maybe she really does have asthma and she's colonized with aspergillus and her presentation is that she has ABPA. At this point, we've talked about several of the things on China. We know it's probably one of these things. For now, we're not looking at a leukemia or lymphoma just yet, or an idiopathic syndrome, since that's something that is kind of more of a diagnosis of exclusion. So of these 3 things, what do you think would be your top diagnosis? So that's where step 4 comes in, with comparing and contrasting these top diagnoses. Which are most likely? What do you think? So if we say like ABPA, is there something that fits or doesn't fit? She is someone with risk factors and that she has maybe asthma. And maybe the thing that doesn't fit is that these patients tend to have more like flare-ups, whereas her symptoms seem like they're persistently uncontrolled, but not necessarily like exacerbations. And then for EGPA, something that considers that this is extremely, extremely rare. There's like a less than 0.003% prevalence of it in the US population. And so, just in terms of statistical probability, we're thinking about the base rate of something. This is something that's really unusual to have. But maybe she could be in a prodromal phase since she's not having multi-organ symptoms right now. And the ANCA being negative doesn't really help or hurt her one way or another. I always ask my residents here to practice writing an assessment and plan for the problem of, well, let's call it chronic cough with eosinophilia. So take a moment to write down what you think, is your assessment of what's happening and what diagnosis you would put at the top for this patient. Here's my example of an assessment and plan for this woman. So my kind of one-liner for her is that she's a young woman with allergic sinusitis who presents to clinic with chronic persistent cough, shortness of breath, wheezing, who's found to have an obstructive pattern on PFTs and eosinophilia, but no improvement with the usual asthma treatment. And for the first problem of hashtag chronic cough with eosinophilia, I said most likely this is due to ABPA, given that this is increased prevalence in patients with asthma, though she's not having kind of the typical flare-ups. And then I would also consider EGPA, since the ANCA can be negative in half of patients, and maybe she's in a prodromal phase, although also acknowledging this is a very rare diagnosis, or maybe strongyloides, given that she's coming from a tropical region that does increase her risk. There's no emergent diagnosis that if we don't diagnose her with it in the next day or two that she's likely to die, but there are some conditions that we can look up, like leukemia or idiopathic hypereosinophilic syndrome, if we don't have any explanation after working up everything else. So what tests should we do? The tests that we do in internal medicine always derive from the differential, right? We always want to make sure that our tests are really going to evaluate the things that we are most concerned about. So in this case, how do you work up ABPA? We talked about checking things like serum IgE level, IgE levels against aspergillus skin test. How can you work up strongy? We can check serologies. Maybe we could even empirically give her ivermectin, see if she improves. And then for EGPA, ultimately we know like the diagnosis for that depends on like a tissue biopsy. But first, let's do some imaging and see if her lungs look abnormal. The fifth step is called committing, and this part can be some of the hardest. What I tell my residents about committing is that it's not about being right. It's about being willing to invest yourself emotionally so that you have put something of yourself into this patient's case, so that if you're right, that feels great and you'll remember the case. And if it's wrong, you'll remember the case even more. That commitment, that emotional investment is what allows the learning process to really stick. So before we go any further, just write in the comments or just say to yourself, what do you think this patient has? We'll still do all of the tests that are for the things on our differential, but do you have a gut feeling for what you think she has? You don't have to be right. The moment of truth, I'm going to show you guys her results. So her serum IgE level was 1600. Her aspergillus specific IgE level was undetectable. Her skin aspergillus test was negative. So this is not really consistent with ABPA. Quantiferin was negative, stool tests and strongyloides antibodies were all negative. She had imaging that showed these scattered subpleural consolidative opacities in both lungs on a CT scan. Presumably she had an abnormal chest x-ray that led to this. And so a biopsy from one of the subpleural lesions showed airway changes related to asthma, eosinophilic pneumonia, and eosinophilic vasculitis with areas of infarction. So this patient was diagnosed with EGPA, started on prednisone with resolution of her shortness of breath, her wheezing in 3 days. That's remarkable. And then she was started on azathioprine, and the prednisone was tapered over a year. All right, so we know the diagnosis now. This patient had EGPA. So to review the steps of how we got here, we defined her problem initially as someone who seemed like she had asthma, just garden variety asthma, and then when she didn't improve with typical asthma treatment, as someone who maybe had a different cause of chronic cough or asthma mimic. When we saw that her labs had eosinophilia, we then used that abnormality as her most specific problem to focus on. So we used the schema for eosinophilia for step 2 to generate, here are the possible causes of her condition. And then for number 3, we matched her specific case with how does it look like when you have EGPA or strongyloides or ABPA, and trying to match her case to illness scripts for things on the differential diagnosis. For step 4, we talked about which of these conditions that are the top 3 seem like they are most likely for her. And then for step 5, we made a commitment so that before you found out the answer, you already put yourself out there. So I hope that this answer will be even more meaningful for you. And then The last step, which I'll add right now, is called the cognitive autopsy. Was there something that we did that you don't typically do that you're going to now start doing more regularly when you're not sure what's going on with a patient? Or if you got the diagnosis wrong, which is totally okay, what do you think it is that led you astray possibly? And is there a step that you think you'd like to do in the future that is going to help you get the right answer next time? So that's what a cognitive autopsy about. It's really is a way of reflecting on our own cognitive process in clinical reasoning so that we can fine-tune our clinical reasoning even better in the future.
Please write in the comments something that you've learned from this case that is going to change what you do in the future. Thank you to the interactive cases as part of the New England Journal of Medicine, where I got this case from. Thank you, everybody.